Love this podcast? Support it and sponsor today. Simply head to ozcastnetwork.com for details.
Hello everybody, welcome to this Talking Tendons podcast. This time I had the pleasure of sitting down with Chris Clifford, who is a tendon researcher just finishing his PhD from Scotland, and we had a really good chat about gluteal tendinopathy, which is one of the ones doesn't often get as much attention. So I thought it'd be really interesting to have a really good chat with Chris about his thoughts and some of the stuff he's done in gluteal tendinopathy space. Thank you very much for listening. Hope you enjoy it. Okay, welcome, Chris, to this Talking Tendons podcast. It's really a great pleasure to have you on. Obviously, we've sort of been talking about your work for a while, so it's really great to have you on. Thank you for coming on.
Yeah, hi, Peter. Great to speak with you.
Fantastic. So I'll just start the way I always start with everybody. Tell us a little bit about what brought you to this point. So basically, I know you've been doing your PhD, you're about to finish, but sort of before that, your interest in tendons and that sort of journey, if you can.
Sure. So I'm a physiotherapist based in Glasgow. And at the moment, I suppose I currently have a kind of clinical, kind of academic role. So 2 days a week, I see patients, mostly tendon patients, and I'm doing some teaching as well at university, and I'm coming towards the end of my PhD. I should hopefully finish that over the next month or two under the supervision of Professor Neil Millar at University of Glasgow. So currently it's a really good mix, being able to combine clinical work, seeing tendon patients, and also with research into tendons as well. So I suppose, so I started my PhD in 2016 actually, I think it was. And I suppose I've been interested in tendons for a while before that. And I just had a clinical interest, just kind of developed into a kind of research interest, but I had clinical questions. And from there, I just started my PhD. And that's where I am up until now.
Fantastic. And as you say, it's a really good mix. Being also someone who does the same thing, and it's not many people. I think when you look at researchers, they do, and this is sort of something for the younger clinicians probably watching and budding researchers. People do tend to specialize in research or clinical work at some point, but combining both can be challenging, but also really rewarding. So that's great, and it does, as you say, give you some questions and give you really good idea of how to do clinical research as well. That's excellent. So tell us about, so basically you've obviously done a PhD in the gluteal tendinopathy area, which I'm really interested in because, as you will know, there's not a lot of research in gluteal. I always find myself in clinical conversations with patients that they, if they've got a gluteal tendon problem, I sometimes share evidence in the Achilles with them or in the patella because it demonstrates a point that I want to make, but because there's no evidence in the gluteal, so you're sort of borrowing evidence from other areas. So tell us a bit more detail about what interests you in gluteal particularly, and also then maybe go into some of your PhD if you can for us. That'd be great.
Yeah, so I think, as I say, my interest for a while has been the kind of lower limb tendons, and I was also interested, and still am, kind of in kind of hip, kind of joint and kind of hip and groin pathology as well. So I kind of combined the two almost, and and done a PhD and started my PhD in gluteal tendinopathy. And I think, as you say, when I was starting out, it was just, I think it was just after the LEAP trial was published. So up until then, there wasn't really much at all in terms of evidence around exercise for these patients. So there are, there's one or two more studies now, but as you say, compared to Achilles and patella, there's not really a lot out there. So the first study I did for my PhD was we looked at isometrics versus isotonics for GTPS, and that was within Glasgow. And I think that probably the reason we did this was, I mean, back we're going back maybe 4 or 5 years. So isometrics then were very, very topical in tendinopathy. But there was only really one study, I think in patella, that looked at isometrics for, in short term, which I think was after kind of 4 weeks. A lot of the other original, Eben Rio study, etc., was looking at, immediate effects. There was nothing really looking at isometrics for, for 4 weeks. And we looked at it for 12 weeks as well for gluteal. So I suppose I wanted to see, could you use isometrics not just for, immediate pain relief, but also as part of, a progressive kind of loading exercise program. So we basically found, I think we finished up with like 23 patients between both groups, and they were the same. So there was really no difference between outcomes for, the participants who did isometrics versus isotonics.
That's interesting. And was there no differences in any of the outcomes that you looked at? I presume you would have looked at, say, pain and function and sort of even some other outcomes.
Yeah, so we looked at pain, and we looked at Visa-G. We looked at catastrophizing as well, pain catastrophizing, and quality of life, and there was really no difference. I mean, I think the study was probably limited by its sample size. As I say, it was 23 participants, so that was maybe a factor. If we had more participants, we might have had different results. But certainly the kind of 4 week mark and at 12 weeks, which was our kind of final outcome, there was no difference.
That's interesting. Let's explore that for a bit, because I think one of the things that you see in tendinopathy evidence in general, and again, going down to the Achilles and even the patella, where we've got a lot of comparative exercise studies like the one that you've done. And I will link this to the show. I'll link this to the show notes as well. It was in BMJ Open. I believe, wasn't it, Chris? I think open.
Yes.
Yeah. So I'll link that. But basically, yeah, you sort of tend to see, and this is one of the things that's frustrating, I guess, for clinicians. You do tend to see a lot of the time that these comparative exercise studies, they end up with null findings. So not any difference between these, seemingly very different exercise interventions. On a group level, there's not really much difference between them. Do you have what's your take on that in terms of, do you have any sort of thinking around what's going on in that case? How can we explain that?
So, I mean, I suppose the difficult thing is it's difficult to know why and how some of these patients get better in response to load. So both groups did, exactly the same amount. So we equalized them for time under tension, etc. So they did the same amount of loading over the 12 weeks. So does the contraction type, does the muscle contraction type matter, that much if the effect on the tendon is perhaps similar? So yeah, it's it's interesting, isn't it? When you compare these groups and these different loading programs, and they seem to have similar results.
That's right. Yeah. So I guess the conclusion that you guys, one of the key conclusions you guys would have come out with is that based on your study, the contraction type doesn't really matter. And you could do, I guess, presumably, I have read your study, but not for a while. Presumably, one of the conclusions was you could do either. Is that right?
Yeah. So I think, there may be patients who, you might see in the clinic who aren't able to do, for example, isotonic exercise. So, an example might be someone who's maybe got, quite, kind of moderate to severe hip arthritis, and they've also got gluteal tendinopathy. So because they've got limited range in their hip, then doing a lot of kind of through range isotonic exercises might provoke their hip symptoms too much. So perhaps isometrics is a good option for those people. So I suppose it gives you options as a clinician. If you if you were to use one program and it didn't make a lot of difference, then you can obviously try another program.
That's a good segue into my next question. So for you as a clinician, you work in the NHS, you presumably get handballed or referred a lot of these patients because your interest in speciality. How would you go about managing a gluteal tendon in terms of a rehabilitation approach? You've probably hinted at some of the things there, but can you just talk us through in terms of your clinical management? Would it be similar to some of the things you've done in your trial work, or would it be different?
Yeah, I mean, I think there'd be some similarities. I think it really depends on the patient. I think in terms of your management and the education that you'd maybe deliver and your exercise, your kind of loading program, they would probably be individualized to the patient. And I think most clinicians would agree that's the right thing to do. But I would probably say there is some aspects of education that I tend to give probably all patients with gluteal tendinopathy, especially when I first, in a first appointment with them. I often discuss, kind of pain and pathology with them, because a lot of these patients, as you probably know, a lot of these patients come along and number one, they either think that they have a trochanteric bursitis, or they think they may have hip arthritis and they're going to need surgery imminently. So I think what I try to do is hopefully be able to reassure the patient and assess their hip and kind of exclude their kind of hip joint, and then kind of focus on their their lateral hip pain and say, look, you may have a bursitis, but it's quite rare. If you look at the kind of radiology studies, an isolated bursitis is really rare. So it's much more common to have gluteal tendon pathology, perhaps with a bursitis or bursal pathology kind of coexisting. So I suppose I try and make the patient hopefully understand that their pain is probably coming from the tendon, because I think that makes it easier when you're trying to get the patient to buy into an exercise program. So I think if the patient believes that they have a bursitis and it's an inflammatory type problem, then they're much more likely to think kind of rest and anti-inflammatories and corticosteroid injections is the first line treatment, and we're really trying to kind of take them away from that. So I think if the patient understands that it's probably, you know, a tendon problem, then I think it's easier to get buy-in when it comes to you know, kind of starting exercise with them.
That makes sense. That does make sense. Do you have imaging for a lot of the patients before they come in to you, or?
Generally not. Generally not. There are some patients who are maybe referred from an orthopedic clinic who have had, they've perhaps had sometimes ultrasound, but mostly MRI. So I suppose that's when it becomes sometimes a little bit trickier, because they might have been told from their scan that they have a bursitis, you know, and you're trying to kind of work around that. But most people will not have had imaging when they come to see you in NHS clinic.
Because they might have been told, I'm just thinking of scenarios, they might have been told they've got a bursitis on MRI, but the main problem actually is the tendon. And they've got this bursa that shows up on MRI. Maybe the tendon hasn't been looked at closely enough, or is not showing up as well as what it might do on ultrasound. I don't know. Is that a scenario that could get tricky sometimes, or?
Yeah, I think so. And often, it's not uncommon that, you know, if someone has a bursitis on MRI, it's not uncommon they'll have had 1, 2, sometimes more injections before you know, they're eventually referred to yourself. And you know, often the injections have not helped, or they've gave kind of short-term relief, but by that stage they're, you know, many months, if not longer, you know, since the symptoms started. So that kind of makes it trickier as well.
So your advice then, so in terms of if you get someone who's got a say pathology, say bursitis that has been shown, plus the tendon pathology, how would you treat that? Would you treat that just as a normal gluteal tendon patient with your loading stuff? Do you pay any special attention to the bursa?
Yeah, I mean, I would just try and focus on the tendon.
Yeah,
you know, I would just try and focus on the tendon and almost try and put the bursa to the side. I mean, I think it probably can and is for some patients, you know, a source of pain. But I try to focus more on the tendon, and I think for some people, that's reasonably straightforward to do, because if I've not had imaging, you know, and I've not, you know, not been told by another, you know, health professional or a family or a friend about bursitis, if someone comes in and they don't have any kind of knowledge at all, that's sometimes a little bit easier than having to kind of, you know, kind of pick apart some of the information and messages they've been given in the past.
Yeah, I agree. It's a really interesting area, that bursa versus tendon, especially in the hip, because as you say, a lot of people will have injections, and a lot of people will have someone, you know, talking to them saying, "Oh, I had an injection and I'm completely cured," and that may happen for some, whether that's just natural history or placebo, or even the effect of the injection was lucky enough to work in some. But yeah, it's a real challenge to get people sometimes thinking they need to not focus on the bursa, but this is a different, you know, this is a condition where, you know, as you say, we're looking at tendon and bursa together, and we're basically looking at treatment for both of them. So I think that's a really, really, really important point. And I guess the way you're approaching it, which I think is a good way, is from day one, education about those two pathologies. So that's really good, Chris. So moving on with a bit of rehab then, just touching on your rehab approach, do you see, what sort of demographic do you see with the gluteals? Do you see like the typical perimenopausal, like the ones that are, you know, mostly come in, and the ones that are written about a lot, or do you see any of the younger people as well? And how do you go about rehab for them? And is there any differences with those groups?
Yeah, so it's definitely a mixture. I think most of the time it will be, kind of middle-aged and older, kind of menopausal females. But I think we do tend to see, a number of kind of younger, again, normally females who are maybe runners, are quite athletic, and they tend to develop, lateral hip pain, and seems to be most of the time it's due to load. It's due to their training. And the type of training, type of load they're doing. But there's a kind of clear history of kind of overload with these patients, and that's often not there with some of your kind of older menopausal patients. They've got they've got similar symptoms, but the kind of history behind it is a little bit different. So I think I think with your maybe you're more kind of athletic, perhaps younger people, then I think often, again, it's education. It's a little bit different as well, because you're almost trying to explain, they almost need to do a little bit less, and almost kind of offload and reduce their activity to allow things to settle, and then build them back up again. Whereas often with your menopausal, who've probably got more of a kind of metabolic component to their presentation, then often you're trying to encourage them to increase their activity, which often they're not really keen to do because they're in pain. So again, it's thinking about education around reducing the fear that they may have around pain and exercising when they're in pain. So I think with your rehab as well, I think you can start at different levels as well. I think you're often with your kind of menopausal, then you're often maybe starting at quite a low level, because they maybe are quite deconditioned, and often have other sites of pain and health comorbidities. So you'll often start, I think, at quite a low level, maybe with bed exercises or quite low level exercise. But with your I think with your athletic type patients who maybe don't have as many kind of deficits in terms of strength, then really you want to try and probably get them up onto their feet and get them doing kind of weight bearing single leg exercises, maybe get them to the gym. So I think your kind of starting point for the kind of those kind of two groups, is quite different.
That makes sense. That differentiation of function and standing. That's a good way to put it. Can I ask about because you hinted on the metabolic side, which I'm really interested in with the perimenopausal demographic that might have more metabolic things going on. What sort of physical activity would you generally recommend? Because obviously with the walking, sometimes it can be quite aggravating for them. Where do you focus on physical activity? Is that one of the things that you would sort of look at, and how do you approach that?
Yeah. So I suppose it's thinking about the patient's goals. If one of their goals is to increase their walking, then you want to be able to get them back to that. But I think it's interesting. I just wonder whether with some of these patients, I just wonder whether maybe addressing the kind of metabolic side of things might be beneficial. So what about if they went to the pool, and they exercise that way? What about if they go on a bike and exercise that way? Yes, they're probably not specifically loading their tendons, but they're probably perhaps addressing some of the other metabolic issues. And if that's been a factor in them developing pain, then perhaps that's what has to be addressed as part of their management. Because if I think for a lot of these patients, you end up doing almost quite a similar tight loading program, but often they don't respond the same. So I think we probably need to, we just probably need to be thinking about how we can kind of manage these patients a little bit more overall, I think.
Yeah, I reckon that's a really good tip for clinicians out there, and that is, and it's not something that is, you know, really talked about even in some of the, you know, expert guidance, I guess you could say. Physical activity, just seeing if you can improve physical activity generally. And there's a fair bit that's talked about, I think, in osteoarthritis with systemic inflammation, and maybe it does have an effect on that. Maybe there are similarities with tendinopathy. So I think that's a really, really good tip to think about, increasing just general physical activity with these people. So this is great, Chris. A couple more questions for you. I wanted to ask about, obviously, a lot of these patients are not your classic sort of, you know, exercising patients, and we've already touched on metabolic and reduced physical activity, which are really key things to consider with these patient groups. Have you got any ideas about how to, and I think you've probably touched on some of this already, but in terms of really, you know, I know with an Achilles, because I see mainly Achilles patients, but I do see a spattering of other tendons. And there are some that I just cannot get better, and they just really just go through, and even despite your best efforts. So I'm just wondering, have you had any real challenging ones, and what do you put that down to, the ones that are really unable to improve? Is it the exercise and we're missing something, or is it other factors?
Yeah, I mean, I think that's the difficult one, isn't it? Because I mean, I think when a patient comes in, you don't really know if they're going to get better, you know, and you don't really know if they're going to respond to what you ask them to do. You know, I think overall, I think the patients that tend to do a little better are perhaps those of maybe they come in with, you know, maybe just single site pain. So they've got lateral hip pain, maybe a history of kind of overuse that's quite clear, no health comorbidities, you know, no other sites of pain. So there's not really any metabolic kind of factors, and it's a purely related to load. So I think those patients, the ones that I see anyway, I think those patients tend to do better than the ones that are just more complex, you know, have got multiple areas of pain, including, you know, kind of lateral hip, and who are, you know, they've maybe got, you know, if you look at their some other factors like psychological factors, which I think can be important for a lot of these patients, you know, if they've very fear avoidant, you know, kind of low mood and, you know, depression, etc. And I think those patients, I think I think they're more difficult, but I don't think there's really any. I don't really think there's any easy patients with tendinopathy. I think you'll probably see the same as me. A lot of patients are often chronic and have symptoms for a long time. So I think they're all. I don't think any of them are easy to manage. I think it's just varying, you know, kind of degrees of complexity. Yeah, I think overall they can take a long time to improve some of them, and I think that's what I say to patients on day one. I'll say, look, this is going to take a while. You know, don't expect anything to change quickly. You know, if things do, then great. But you know, this is we can't really cut any corners here. This is going to take a long time, and I think that often I think they ought being honest with them. I think that's. That helps with kind of buy-in as well. I think if you promise them the world and say things will start to change quickly, and I think you're just setting yourself up to fall, because for the patients that I kind of see, that kind of rarely happens.
there's so much in that is helpful for clinicians. So things like looking at sort of multi-site pain as potentially something that's going to take a bit longer, because they often do present with back and other issues, and looking at some of those psychological factors even. And we've talked about the metabolic factors, and then buy-in, setting expectations. So I think that's really some important tips there for clinicians in terms of this demographic. And as you say, it's really it's great when they improve quickly, but they don't often improve that quickly. And it's it's really good to be setting them up for that expectation as well. Now, last question. This is something that I pretty much ask everybody. Just wanted to, so obviously with your experience in gluteal, your clinical work, your research work, what are the things that you think have changed in your practice the most? If you were talking to a young clinician now, what would you sort of give them the heads up on as a top tip for managing this group of patients? What's the thing that they must do when they're managing gluteal tendinopathy?
Yeah, I mean, I think as a clinician, I think you need to be patient. I think the patient has to be patient as well, because as I say, it's likely that you're going to be working with the patient for many months. So I think you need to probably have confidence in what you're doing, and the confidence that you're going down the right path with the patient, and just stick with it. If things aren't changing, after 4-6 weeks, something like that, then I don't think you're necessarily always doing the wrong thing. I think I heard Karen Silbernagel speaking recently, and she was talking about, again, some of these patients who we see, Achilles and gluteal, who are probably have a kind of stronger metabolic component. She thinks they just need a little bit longer, some of them, and they're not all going to have a great outcome after 3 months, when a lot of these kind of trials kind of stop. So, and I think I agree with that. I think some patients just need a little bit longer. So I think you just need to have patience with some of them. And I think we need to just accept, tendinopathy and gluteal tendinopathy, it's a kind of biopsychosocial condition. I think it's expecting, a patient to, make, significant improvements across the board after an injection. I just think it's just it'd be great, but I just think it's far too simplistic. I think if you look at these patients, and there's so many factors which are relevant to their pain presentation. So I think loading is important, and I think that's going to be your kind of first line treatment for a lot of patients. But I think there's so much more that we need to probably trying to kind of research for this patient group, because I think there's a lot we just don't know. And I think we need to, in terms of treatment, I think we need to have more treatment options for the kind of people that don't respond to exercise, because it is unfortunate there's a lot of them.
That's great. So unpacking that, there's be patient, but also think broadly biopsychosocial, persistent pain. It's going to take a long time, which I think is really important, untangling those biopsychosocial links. And as you say, there's a lot of work for us to do. And I know that you're going to be doing some in the future in this area, and hopefully a lot of other people, so we can try to understand these more. But I think you're right. The trials finish at 3 months. We just, that's often not enough time potentially for a lot of the patients that we see. That's really fantastic, Chris. Thank you very much for joining me today. There's some really good info there for clinicians. And I do appreciate your time, because I know you're in the throes of completing your PhD and you've taken time out in your evening to do that. So thank you very, very much for coming on.
No problem. Pleasure. Great to speak with you.
Likewise, Chris. Good luck with the rest of your PhD. See you, mate.
Right. Thanks, Peter. Bye.
Love this podcast? Support it and sponsor today. Simply head to AuscastNetwork.com for details.